Good afternoon, everyone. Welcome and thank you for joining us today. Today's webinar, Malnutrition in Adults with Dysphagia, Strategies for Prevention, Detection, and Management, will be presented by Professor Heather Keller from the University of Waterloo and the Schlegel University of Waterloo Research Institute of Aging. I am Erin Bailey, Medical Affairs Manager with Nestle Health Science, and I am your moderator for this webinar. At the end of the webinar, there will be time for questions, so if you could please enter your questions into the Q&A box to the right of your screen. Professor Keller is a Schlegel Research Chair in Nutrition and Aging at the University of Waterloo and is an internationally recognized expert in geriatric nutrition assessment and treatment. Her research areas focus on nutrition risk and malnutrition identification in treatment across care sectors, improving nutrition care processes and implementing screening and other best practices, supporting food intake of diverse groups living in the community, including those living with dementia, and improving hospital and residential food and promoting food intake and the mealtime experience in these settings. Professor Keller has led several national research and knowledge translation projects, including the landmark nutrition care in Canadian hospitals, More to Eat, and Making the Most of Mealtimes in long-term care studies. Professor Keller has published more than 250 peer-reviewed articles and translates much of this evidence into practice with tools and resources. As a founding member and past chair and co-chair of the Canadian Malnutrition Task Force, she is involved in translating research into practice and advocating for improvements in nutrition care. She is currently the co-chair of the Primary Care Working Group for the Canadian Malnutrition Task Force and involved in several national and international expert groups advancing the prevention, detection, and treatment of malnutrition. We are very excited to have Heather Keller leading this webinar today, and I'll turn it over to her now.
Great, thanks very much, Erin. Can you hear me okay? I think we're okay. All right, we'll go ahead. So I'd like to acknowledge that I live, work, and play on the traditional territory of the Attawandaron, Anishinaabe, and Haudenosaunee peoples, situated on the Haldeman Tract, the land promised to the Six Nations, that includes 6 miles on each side of the Grand River. These are my disclosures, and there's no commercial interest in this presentation today. The learning objectives today are: why are patients living with dysphagia at risk of malnutrition? How can we determine if someone is malnourished? Practical tips for families and persons with dysphagia on how to manage meal times. And finally, going over some tools and resources available to assist families and patients with dysphagia who are malnourished. So let's talk about dysphagia and malnutrition first off. So this is a model, a conceptual model, if you will, of determinants of malnutrition in older adults. And this was developed by a group in Europe with Dorothy Volcker as the lead author. And I like this model because it identifies why malnutrition might be occurring in an individual. On the inside part, you see MN, which means malnutrition. And the darker green triangle are the 3 mechanisms by which malnutrition can occur: low intake, reduced nutrient bioavailability, and high requirements. The lighter green triangle talks about those direct determinants of one of those 3 mechanisms. And then the yellow triangle is more indirect factors associated with malnutrition. You'll see that dysphagia is considered a direct determinant of malnutrition because it's well known that dysphagia is associated with people being malnourished. So let's talk about that a little bit more. There's a variety of studies that look at the association between dysphagia and malnutrition, but I've just selected 2 slides for you today that are pretty recent. The first was a study done in psychogeriatric hospitals in Spain, and in an 18-month follow-up. People with dementia were part of this study as well. Dysphagia was diagnosed upon admission, and the family was educated on a modified texture food diet and supplements if the person was malnourished, as by the MNA short form. The follow-up was for 18 months. 85% had signs of dysphagia using the VVST, which is a pulse oximeter when people are giving varying amounts and consistencies of fluid. And those who had more severe dementia and were older were more likely to have dysphagia. You can see that a variety of consistencies were provided to these individuals in terms of both fluid and solid. And 51% of these individuals who having dysphagia were also malnourished, and 45% were at risk for malnutrition. So almost 100% had some level of nutrition concern when they also had dysphagia. At follow-up, 12% did not follow their solid food and 41% did not follow their fluid recommendation. And that I brought that stat up specifically because it deals with some of our items we'll be talking about a little bit later in this conversation today about how we can support families and patients to keep with a modified texture fluid diet or food diet. The second study that I wanted to highlight was looking at people post-COVID with their hospitalization, again in Spain, and the mean age of this sample was 69 years. VVST was also used to determine dysphagia, and 40% had dysphagia on admission. They were more likely to come from a nursing home or intermediate care and were also older patients with COVID-19. 99% of those individuals were at risk for malnutrition using the NRS 2002. 63% had weight loss despite overweight BMI, and 39% were malnourished at discharge using the GLIM framework. We'll talk about GLIM a little bit later as well today. 95% of those with dysphagia had nutrition risks. So again, showing this very important overlap between dysphagia and malnutrition. And 54% were diagnosed with malnutrition using GLIM criteria at discharge. This is significantly higher than those without dysphagia at about 31%. So again, dysphagia is highly associated with malnutrition. And finally, to show you the overlap with dehydration as well. This slide is based on a variety of reviews looking at modified texture fluid in dysphagia and dementia. There is very limited evidence around dehydration actually and dysphagia, but what there is shows that there is a strong likelihood of dehydration. So about 44% of those with dysphagia are also having potential dehydration. And the lower fluid intake is seen in those with dysphagia. So for example, one of the studies identified that 7% of people were meeting the requirement who had dysphagia versus 33% of people who were on normal fluids were meeting the requirement. So there's this overlap between malnutrition, dysphagia, and dehydration dysphagia that we're going to highlight further today. I wanted to talk about a newer concept that's been evolving recently around the idea that some dysphagia could be considered sarcopenic dysphagia. This would mean loss of muscle mass and strength in the muscles that regulate swallowing. I didn't have time in this presentation to show you some of the literature that shows the overlap between sarcopenia, malnutrition, and dysphagia. But this is a little bit different. This is actually talking about sarcopenia in the structures around the swallowing mechanism that everyone has. This could be the strength and thickness of the tongue. The genohydrate muscle could be affected, or the pharyngeal wall thickness could be thinner, as well as weaker contractility. So sarcopenic dysphagia is a multifactorial condition. As you can see on the right-hand side, there are several inputs to why someone might become sarcopenic dysphagic. So they could have swallowing dysfunction already, which could lead to poor food intake, for example. But also there could be bone frailty that affects structures in the jaw, poor oral health that could impact dentition, obviously, and perhaps swallowing capacity. Malnutrition could impact that oral health as well as sarcopenia. And then also multinutrition affects swallowing dysfunction. So you see this circular pattern that goes on with respect to dysphagia or sarcopenic dysphagia and the multifactorial causes that are being input into this specific condition that we're now talking about. The key is it's quite complex, and we're still at the early stages of understanding what sarcopenic dysphagia is and how to measure it, for example, and how to specifically treat it. But we do know that it's significantly associated with malnutrition and sarcopenia. So moving on a little bit further, if you think about bone frailty, sarcopenia, swallowing dysfunction, malnutrition, and poor oral hygiene, which are also from the same paper that talked about this sarcopenic dysphagia, you can see around the outer bands of this circle other conditions that we might be able to measure and think about when thinking about sarcopenic dysphagia. But the key again here is they're overlapping. So for example, low muscle mass is something we see not only with sarcopenia and bone frailty, but also we see in malnutrition and swallowing dysfunction. And so we might be wanting to think about measuring some of these specific components that could lead us to a diagnosis of sarcopenic dysphagia. The key is we should be screening malnutrition, screening for dysphagia, and screening for sarcopenia, as well as bone frailty and other conditions here that could be overlapping when it comes to sarcopenic dysphagia. As I said, this is a very new area of research. I'm sure we'll find more on this over the next, see more coming out in the research in the next few years around sarcopenic dysphagia, specifically how to assess it and how to treat it. So why is malnutrition so common in persons with dysphagia? If you remember the DOMAP, or the determinants of malnutrition model at the very beginning, the triangles that I had, the one mechanism that's probably the most influenced by dysphagia is the poor food intake mechanism of malnutrition. And if we think about that poor food intake mechanism, the three things that we know from research suggest that why dysphagia might be associated with malnutrition are around the food product itself and eating challenges that the person may have. When it comes to the food or fluid product, we're thinking about nutrient density of that product, as well as the sensory appeal and the acceptance of residents or patients of those products, or lack of acceptance that could lead to poor food intake. And then we also know that individuals who have dysphagia often also have eating challenges. So they may have challenges self-feeding, they may have challenges with attention, they may have challenges with when they are being assisted by someone else not being as receptive to that for whatever reason there may be. So many reasons why the poor food intake mechanism results in malnutrition when individuals have dysphagia. I want to show you some data from the Making the Most of Mealtime study, that's M3 here on this slide. Basically, some of the resident characteristics and intakes. So you get a sense of the overlap again between dysphagia and malnutrition and whom might be at greater risk. This is a very large study in over 600 residents from 4 provinces in Canada. And you can see the prevalence of malnutrition risk at 44%. The use of thickened fluid was 11%. IDSI standardized textures was 47%, but the IDSI 4 to 5 level was only 32%. 39% had irregular saliva, which is important when you think about, again, swallowing, the dryness of the mouth and the throat structures. So obviously some significant concerns with respect to dysphagia and malnutrition in this sample when using the M3 data set. Just to note here, the prevalence of malnutrition is based on the PGSGA. If we look in more detail at the different IDSI levels with respect to fluid and food intake, or food intake here specifically, I should say, we can see some differences as well. And those that have an asterisk behind them on the left-hand column were significantly different by the texture levels. So IDSI 7, of course, is a normal texture at 53% of the sample, and then 6, 5, and 4 are listed here in the columns. You can see that individuals who have a low BMI are more likely to be in IDSI 5 or 4 levels rather than 6 or 7. So the minced or moist and the pureed textures. The low calf circumference is also more likely to occur in those with IDSI 4 and IDSI 5. Again, indicating sarcopenia in this case. Low calf circumference is a screening or proxy for sarcopenia in older adults. Oral nutrition supplement use was also higher in those who had any modified texture, 6, 5, or 4, as compared to 7. But you can see the gradient of increased use of that oral nutrition supplement with the more refined products like IDSI 4 pureed. And again, assistance to eat. So I noted before that the mechanisms, eating challenges, are one of the key areas of why someone might not be consuming enough food and fluid if they have dysphagia. And you can see here again, the prevalence of those requiring that assistance is very high when someone is requiring a pureed diet at almost 79 or 80%. So are people who are on modified texture food and food diets eating enough? And we can see here that there are some differences, that people that are, we have it categorized by males and females. You can see that in general, females eat less than males, obviously. But when we have the IDSI 3 to 5 categorized together compared to the regular, you can see a lower intake as well of energy there for you. What you won't see, though, is the gram per kilogram per day of protein being lower. And this is because these individuals are actually lighter that are IDSI 3 and 5. If you remember the prior slide, a higher proportion were less than 18.5 for the body mass index. And so if you look at protein as relative to body size in terms of kilogram body weight, it actually goes up as a result. Fiber intake was also lower, as you can see, and we don't have the separation out, unfortunately, by the IDSI category for fluid in this slide, in this study. If we look, though, at individual micronutrients, we do see some differences as well. So in general, in the M3 study, we found several nutrients on the left-hand side of your screen where more than 50% of the sample had low intake. They were not meeting the dietary reference intake. What I want to refer you to is the right-hand side where we see modified texture food consumers consuming less than the regular texture consumers. And the M and the F are for males and females here. So males were consuming less folate, iron, selenium, and sodium if they were on modified texture food diet as compared to on the regular. And females were consuming B1, B2, niacin, folate, K, iron, and selenium, and sodium less than the regular consumers. However, there were some nutrients where modified texture food consumers actually ate more than the regular. Vitamin C specifically, vitamin D, calcium, and zinc for men specifically. So there are some components of the diet which are better with the modified texture. It's probably because of the way that they make the product and serve the product. Think about vitamin C specifically, for example, when you puree down fruits and vegetables, they get into a smaller amount, and so they offered a larger portion of those to individuals. That probably means that why we see the higher vitamin C content for these individuals in their diet. So do we know if malnutrition is associated with modified texture food use? And this is a regression analysis based on using the MNA-SF score, so the Mini Nutrition Assessment short form score that we also collected in the M3 sample. And we use that score because it gave us a numerical value, which is a little bit nicer to use for analyses such as this. This is a model that is showing that when we control for the other factors that are in the model, what is the independent effect of those individual items? So this means minced and moist had a lower food intake as compared to regular, had a lower MNA-SF score as compared to regular consumers. And the pureed similarly had a lower intake of, lower MNA-SF score as compared to regular consumers. That's when we controlled for age, as well as being male or female, oral nutrition supplement use, their cognitive scale, as well as EdFed, which is a eating challenges scale, and oral health affecting their food intake. What you see here is that the minced and moist specifically was significantly associated with that MNA-SF score, but pureed was not when controlling for the other factors. What this tells us is that the diet itself is associated with malnutrition when we control for things like oral health and eating challenges, which is an important finding. Most of the results published before this have not taken into account things like the person's cognitive status or eating challenges when looking at the association between malnutrition and modified texture food use. This is an important finding. So what impacts the modified texture food use, especially in long-term care and perhaps in hospital settings as well? Well, there's insufficient food funding and staffing that we know. Again, in the M3 study, we showed that it varied by province how much funding was available for both the raw food cost as well as staffing. But also within provinces, it can vary by home and hospital. And this can be put down to potentially insufficient skill or prioritization of the menu as well. The facility environment also can have an impact. Is the menu and food itself a priority, the quality food production? Is there a frequent menu revision that allows for variety and for residents and patients to not get bored with what's being offered? There could be policy constraints. Specifically in long-term care, there was a requirement for a long period of time that the pureed and the minced food, moist and minced foods, should match the regular food in terms of their content and their description on the menu for consumers, so that there was a close match and people felt they were getting the same foods. As well, homes might decide to purchase a commercial product for a variety of reasons. They might be concerned about food quality that's in-house, They might also have a philosophy around food production where they want to make it all in-house. They don't want to use commercial product. It might depend on the number of patients or residents that are requiring modified textures. It's only a few, for example, it might be more efficient and cost-effective to buy commercial products, which might then be limited in their variety because of the way they're packaged. And also we have to be thinking about staffing capacity and environment for a consistent product when it's being made in-house. So all those can influence, would someone choose to purchase a commercial product versus making their modified texture foods in-house? You can certainly talk about more of that during the question period if you like. So now's an opportunity for us to do polls 1 and 2. So if we could do that, that'd be great. I think we have a lot of people online today, so maybe lots of.
Okay, so the answer is D, all the above.
Which I believe is correct.
Yeah, this is okay.
Great.
Yep.
And
then this, apologize, the second poll question. What are the constraints that long-term care homes and hospitals may have with modified texture foods?
And the options, Erin, are, I'm not sure I remember.
Yep, so the option A is insufficient staff to prepare. B, not enough food funding. Option C, concern about consistency with in-house production. D is food is not a priority, and E is all of the above. I'll give a few more seconds. Okay, results are in. All of the above at 95%.
Great, so people are tracking with my content, which is terrific. Thanks very much, everybody, for that. So move on. So one of the other objectives was to talk about determining malnutrition. And I just want to remind folks of the definition that we use for malnutrition. And again, it's more of an undernutrition definition, of course. It's inadequate intake or assimilation of energy, protein, and or micronutrients. And when someone has sustained inadequate intake, assimilation, and leads to change in the body composition function, this is when we call it malnutrition. Okay. And so it has to have that sustained inadequate intake that leads to functional change in the body, such as muscle loss. So when I think about nutrition risk to malnutrition, I think of it as a linear process, although it probably isn't totally linear. And you can see that on the prior slide, that first part about nutrition risk was really that first part, inadequate intake of the nutrients. That's what we see happening often in older adults with dysphagia. It may not be actually malnutrition, though, until you see that loss of weight, that tissue change that's happening, loss of function, and adverse health events. The key, though, is there's lots of determinants and risk factors, and this is where dysphagia sits, if you remember that triangle model of determinants of malnutrition at the beginning. I want to show you this again because when I talk about how we determine risk to malnutrition, it's important to understand these differences. So when we think about identifying malnutrition, there's a 3-step process that we should go through. We should screen, and I've got on the right-hand side some of the tools that might be useful for hospital, community, and long-term care settings. In hospital, we might use the CNST, the Canadian Nutrition Screening Tool, or the NRS 2002. In the community, we might use a screen tool or the M&A Mini Nutrition Assessment short form. And in long-term care, it's up for debate what we might use in that setting. MNASF tends to over-identify people that might be malnourished in this setting, but it might be the best tool in terms of screening. The next step would be to assess. And I know that much of the audience is dietitians, and you'll be glad to know that the gold standard is a comprehensive assessment by a trained clinician, like a dietitian, to determine if someone is malnourished. However, we see in the literature standardized measures that are used because we have to ensure that there is commonality in the way that we identify malnutrition. So you can use subjective global assessment, patient-generated subjective global assessment, the M&A full form, or the Aspen criteria to standardize our diagnosis of malnutrition. Our diagnosis of malnutrition. And then we can use a diagnostic framework, which should be based on clinical judgment if we're using a comprehensive assessment by a dietitian. But again, those standardized assessments tell us, yes, someone's malnourished versus not. And this is where the GLIM diagnostic framework comes in. GLIM is not a full assessment. It is not, does not compare like, is not comparable to SGA and PGSD or MNA full form, or the Aspen criteria in terms of covering all the aspects of malnutrition. And we'll show you that on the next slide, how they compare out. The GLIM is based on the occurrence of one etiologic and one phenotypic criteria, and there's a selection of 5 of those that can be looked at in terms of identifying someone to be malnourished. I won't be going through that in more detail at this point, but want to emphasize that it's not a full assessment for individuals. If we look at the different tools in terms of risk screening, you can see that some of them, again, are based on the determinants of risk factors on that far side, which would be more appropriate for community settings. And then those tools that are looking more at weight loss specifically, and perhaps even change in tissue, like the SNAC looks at arm circumference, that would be more on the malnutrition side of things. When we look at malnutrition or screening tools that include swallowing, there's actually only 2 that pick up swallowing function. Screen being a nutrition risk screening tool meant for community living older adults. Asks the question, do you cough, choke, or have pain when swallowing food or fluids? And the person indicates never to always. And the mini nutrition assessment, short form or full form, has this one question about, has food intake declined over the past 3 months due to loss of appetite, digestive problems, chewing, or swallowing difficulties? And again, you can see the range there. So swallowing here is put in with a variety of other factors. It's not alone, so it's not specific to swallowing. I wanted to show you, though, when we're thinking about that comprehensive assessment by a dietitian or another trained clinician, this is what we would typically try to look at in various components of nutrition assessment. So diet, function, physical exam, anthropometry, biochemistry, and clinical factors. And you can see when I put on the standardized assessments here, like SGA, MNA, and Aspen, where do they actually pick up on a component of this comprehensive nutrition assessment? Sorry, it jumped ahead on me. Must have a automatic moving ahead. So you can see that all the standardized assessments cover the components, some of the components of a malnutrition assessment, excepting biochemical. That's one component that's not being picked up by the standardized assessments. And you can see as well that the SGA picks up most of the components, whereas Aspen picks up about 4 of them, and MNA picks up several of them, but is missing out on the physical exam component here. Just show you how they compare out when thinking about a standardized assessment and the components of that. Let's go on to poll 3 now. So this question, Erin, is?
Question is, what malnutrition tools include a question on swallowing? Okay, a few more seconds. So 86% answered D, screen and MNA.
Great. Again, that's terrific. Everybody's listening well. That's good. So we move on. So let's talk about improving food texture. I'm just going to speed up a little bit so we have some time for questions as well at the end. I know that interruption we had took us some time. So I'm going to refer to 2 key, this position statement and a guideline when thinking about how can we optimize nutritional intake for people with dysphagia. So this is the only guideline that I could find specific to dysphagia. And it's the working group position statement from Japan. They talk about multidisciplinary care is key to addressing malnutrition and dysphagia in persons with dysphagia. All those with dysphagia require nutrition screening or assessment. And we should be using standardized textures to manage individuals with dysphagia. We need to individualize how we provide those to individuals. It might be switching out some of the textures depending on their capacity. We should be fortifying foods. We should promote sensory appeal of those foods. And where required, when someone is malnourished and they're not getting better with food alone, we should consider an oral nutritional supplement. The other guideline that I want to focus in on is the nutrition and hydration guideline put up by Volcker and colleagues, again from Europe, from the European Society for Parental and Enteral Nutrition. This is more for malnutrition prevention in general, nutrition in general, but it also had some key components around dysphagia that I've pulled out. And in addition, I've added in what Desir, who talked about sarcopenic dysphagia, specifically also recommended. So in persons with dysphagia, we should be screening for malnutrition. The care should be individualized and multidisciplinary. People should be consuming 30 kilocalories per kilogram. Of course, that's individualized if they are overweight to a lower value. But if they have sarcopenic dysphagia, we should be thinking about 35 calories per kilogram body weight. For a person that we're trying to prevent malnutrition in, who has dysphagia, we should be giving them 1 gram per kilogram protein at least. And if they have sarcopenic dysphagia, this should be higher at 1.2 to 1.5 grams per kilogram per day. Fluid intake, 1.6 liters for females and 2 liters for males. Again, this is to prevent dehydration in older adults, and to use appropriate modified texture foods that are enriched, because it's well known the overlap between dysphagia and malnutrition. So what do consumers actually think of pureed foods specifically? So pureed food tends to be the one that people most complain about in terms of textures. It's not what they want to consume. It has some challenges. So just reads over some of those quotes that I have here for you. So this was based on a study that I had done with people who consume pureed food who were living in long-term care or in chronic care hospitals. And the key overarching theme, if you will, of this qualitative data analysis was that pureed food was the indistinguishable food in terms of color, in terms of taste, in terms of how it was presented on the plate. And so it was leaving much to be desired by residents and patients. So how can we go about improving modified texture foods? Well, we should be using the right texture for the individual, and IDSI helps us to standardize those textures for sure. We should try to present the food in a way that's appealing to individuals. For example, adding a nice sauce. So you can see here, you wouldn't necessarily put pepitas on a squash soup, but to show you that contrast that could be made available by using a spice, for example, on top. Try to promote sensory appeal, even if the visual food and the texture is changed for people. Try to, with color, by the way it's presented on the plate, in a very appealing way. And this can be done through molding, piping, or 3D printing of food, which is a very novel strategy. We're not there yet in production-wise to be doing 3D printing. I've done a study in that area. We could talk about that a little bit later if you like. Promote nutrient density of the food, enhance the food, both in flavor but also in nutrition, by fortifying if we can or where needed. So this study was a very nice study that showed that when we standardize just the texture of the product by thinking about standardizing the portion size, the use of thickener, and controlling the viscosity, we can actually promote better intakes. This was comparing 20 people getting the standardized texture diet versus those with a traditional diet that was unstandardized in terms of portion, use of thickener, etc. So all those problems we often see when people are making their product in-house with an unstandardized product. When it was standardized, the intervention group, which is the darker black line here on the graph, you can see increased energy and protein intake as well as body weight. And we see hand grip strength also increased for these individuals. So improved intake as well as body weight and function. So some things we can do to improve the sensory appeal, we can think about, and nutrient density, we can think about micronutrient fortification and pureed. There's some research that shows that when we do this, we actually see improved serum levels of micronutrients in the blood of individuals. By molding and enhancing with canola oil and whey protein, in one study they showed increased intake and promotion of body weight. When food was reshaped, and it was found that the food increased intake and body weight. However, we need to avoid excessive use of thickeners because that can affect the perception of the food itself. It can be dry or not seen as positive when it's molded that way. So there's a delicate balance between enhancing the appeal of the food by reshaping it, but not making it excessively changing the taste profile or the look of the product by excessive thickener as well. Nutrition in Disguise is a project that I developed several years ago now, where we tried to enhance food products for use specifically in long-term care, recognizing the menu deficits that we saw with the Making the Most of Mealtime study, and recognizing that by simple changes in ingredients, we could enhance the micronutrient content and protein content of food that was being provided to long-term care residents. So I would encourage you to look at the information on the website, the Research Institute for Aging website, around the different recipes we have, and this open access publication that talks about that study in more detail. To further promote intake beyond the food product, think about some other things that could be happening in the environment as well. Remember, eating challenges were also a significant reason why people who have dysphagia might not eat enough food. So there's other things that we can be thinking about. So continuity of staff to provide support in a way that's always welcomed by the resident. Making sure we're not working in silos, but working together in terms of the food service and nutrition departments with the nursing departments that are often assisting the residents and patients to eat. Think about the physical environment, something that has less noise, smaller dining areas, a more social eating environment, culturally familiar foods that are more palatable, flexible meal times, staff education on nutrition, hydration needs, and frequency of offering these food products to individuals to support the nutrition, and having available thickened fluid between meals as well. All of these could be other ways that we could promote food and fluid intake for the person that has dysphagia. I also want to help us remember that the patient resident should be at the center of all of our planning. We need to balance safety of sewing with quality of life. Because of the acceptability of sometimes the product, even when it's a good product, people may not be wanting to eat pureed food. And so we need to think about balancing that risk and benefit of the modified texture. This is where the individualization in both of the position statement from Japan and the Volcare ESPEN guideline talk about the need to individualize our recommendations for folks when it comes to this to promote compliance. We can do a trial of various strategies to promote the pureed food in different textures as well to be what's acceptable and safe for the resident, and reassess the resident patient too. Their swallowing capacity might recover if they're post-stroke, for example, or post-intubation. And so reassessing that food and fluid acceptability and safety is important as well. So some practical tips for families and patients. So many foods are actually normative in terms of being pureed. And so thinking about those foods that are on the slide, for example, that can be promoted in the diets of individuals that are trying to consume pureed food at home or in a long-term care center. Offering one of these at every meal can be a way to promote the food and fluid intake of an individual. In addition, we can think about making pureed food specifically more appealing. Again, some things listed out here that I've already spoken about, but thinking about a colorful spice or garnish to make a pureed food look nicer, for example, parsley, paprika, or cinnamon. Add spices after blenderizing as well to promote the flavor, but not overdoing that flavor. And try new things to promote variety as well for individuals. Using a sauce that's a contrasting color, like, for example, pureed turkey with a very nice cranberry sauce on the side. And try to have discrete foods versus mixed foods. The research that we did in this lab, when people were talking about pureed food, they often would see a mixed dish like a casserole, and the main flavor would overtake all of the flavors, unfortunately, in that food product. And so a mixed dish was often not as well received as discrete food products. So some other ideas here that you can support intake specifically of pureed foods. And again, some tips here around pureeing. Because we're short on time, I'm going to just skip over that slide, and you can look at it a little bit later if you're interested. But how we can think about boosting nutrition again for modified texture food and fluid consumption. Adding energy, whole milk, cream, coconut milk, cheese, etc. Adding protein with pureed lentils, beans. Mung beans, red lentils really puree very, very nicely and can add the protein to the diet, as well as tofu, protein powders, etc. Think about eating small, frequent meals to boost the nutrition of people as well. We tend to find that people might not be willing to eat as much. They might have tiredness that affects their ability to consume a larger meal. So think about how we can do that, and thicken with things like skim milk powder, potato flakes, breadcrumbs, and leftover mashed potatoes that can add some nutrition back into the food for people that require that modified texture food that requires a thickener. Just a quick note that we know that when people who have dysphagia are assisted by their family members, they tend to eat better. They eat more protein and energy based on a sub-study that we did on the Making the Most of Meal Times. This was 56 people that required eating assistance and had family also assisting them on occasional meals that we observed during our study and saw this improved intake. Of note, these people, as I said, had dysphagia risk and were more likely to be in a dementia care neighborhood, so had dementia as well. What do volunteers say about providing eating assistance to people with dysphagia? They really need to learn how to provide quality assistance, so focusing on eating, and they value that consistency of a person assisting them. They see the value of promoting autonomy and dignity for the person who's being assisted, starting with their favorite foods, and developing as well those social relationships with residents and patients who require eating assistance to help promote that food and fluid intake at a meal. So we have our final poll, and then we'll be able to go on to our wrap-up.
Would not be a pureed texture food. And to access the polls, just go to underneath the Q&A, and there's a poll box. You just click on to answer your question.
And what are the question options again? Or the response options, I should say?
Yep. So there's quiche without crust, hummus, grits, yogurt, and none of the above. Okay. You've got some answers coming in now. Got a few more seconds left. Okay, so quiche without crust was 41%, grits 37%, and none of the above was 21%.
Okay. Depends on how the grits are made, I guess you would say, how fine they are, for example, and if the quiche has anything beyond eggs in it, right? So that could be a concern as well. But good to check your knowledge there. All right, let's go on to our conclusion. So residents with dysphagia are vulnerable to poor food intake, malnutrition, and dehydration. I think I've shown you that with the data from a couple of studies, as well as the Making the Most of Mealtime study. We know that, again, for the Making Most of Mealtime study, that modified texture food diet itself was predictive of malnutrition. It couldn't be put down to eating challenges or cognitive impairment. And we don't have the data for dehydration, but we can expect that it would also be associated with dehydration in older adults who require modified textures. We should have a judicious use of modified texture food levels and consider the risks of using, especially as we move towards the pureed texture and the thicker fluid textures, which might be less acceptable to patients and residents. We need to work towards improving modified texture foods to make it practical and feasible. Improvements are really needed. And so this is where nutrition in disguise comes in, trying to make it very practical, changes to menu options and to recipe options that are using ingredients that are available or can be made readily available in long-term care and hospitals. We should standardize and improve the sensory appeal and enhance nutrient content of modified texture foods. We need to use recipes for molded and enhanced foods to promote, again, nutrient-dense products for individuals. And finally, make sure we pay attention to the resident's choice and quality of life. These are paramount when thinking about the importance of food to individuals' lives as well as to their nutrition. So with that, I thank you very much for your attention. Here's some resources and recipes I found when I was doing some work on this presentation that are specific to pureed food and making mechanical soft diets. Thank you very much for your time. Hopefully we have a few minutes for questions now, and we can go.
Okay, perfect. There is some questions. We have some questions in the chat. I do want to let everybody know as well that there will be a link to the recording as well as the slides. Will go in an email in the upcoming 2 weeks out to everyone that has participated in the webinar today. So so that will be coming out. That was a lot of the questions, but we'll start. Here's the first question. How are you diagnosing sarcopenic dysphagia?
It's not available yet, really, quite frankly, to diagnose it. It's a pretty novel concept. I think bringing awareness to it is the key thing. We typically determine sarcopenia through a variety of measures, as you know. We need to not only measure muscle mass, but also muscle strength to determine a sarcopenia. So sarcopenic dysphagia, thinking about the mass, how would we do that? Perhaps with ultrasound, perhaps. That's up in the air at this point in time, unfortunately.
Okay. And so the other question, second part to that question was, who would diagnose sarcopenic dysphagia?
Yeah, I think that's a really good question. So this is, I think it takes a multidisciplinary team to diagnose and manage dysphagia, as you well know. Perhaps it's in the realm of the speech language pathologists, depending on what tools are available to them. I'm not sure yet. It's an interesting notion, but we have to start thinking about that. Of course, we're going to be identifying who should be trained to do that, right? To do it well. I can imagine muscle strength or tongue strength. There are some measures that are available for tongue strength, and they can be done by speech language pathologists. So that's something that might be worth looking into.
Okay. Another question was, I feel I have lots of good ideas for helping the residents. But the care plans are not always followed. Do you have any tips to help with this, to support the care plans?
Yeah, I think it comes down to communication, right? And so those folks that are often either plating the meal or offering the meal to residents that might require eating assistance, for example, don't always communicate well. And the dietitian, I've run into this with numerous times, a dietitian myself and others included, that can make wonderful notes and try to communicate across the group. So I think it's training, and in-servicing for your diet team, especially who's plating the meals. And then again, with the team members who are serving the meals to the resident through requiring eating assistance, some in-service around, keep the food discreet. They appreciate that. You can think about doing a variety of meaningful ways of but offering pureed food to those folks that are actually assisting residents to eat, and show them it doesn't taste awful like you think it does. But if you mix it together, how does that feel to be eating it like that versus discrete products? So I think using innovative ways to get the message across about the importance of it. And when a change is made, documenting it and communicating it as thoroughly as you can is key in keeping on top of it, right? As a dietitian, when I was practicing, I like to do mealtime rounds. That's where I could see that things were happening or not. That's not always feasible. But if you're in the home during a meal, that's a great time to see that your prescription is being ruled out appropriately. And so it would be an important strategy for you to use.
Okay, perfect. How do you address the funding in order to increase kitchen staff in order to prepare the foods? What are some suggestions or recommendations that you might have to help support that?
Yeah, I think because of the growing need for modified texture foods, especially in long-term care, I think it's worth actually advocating that when we have a person who requires a modified texture, they should get more money for food in that home, because it does take that extra effort with thickeners or with time to make a quality product, right? And so, or if you don't have many residents in your home, you might have to be buying commercial. It can be more expensive as well, depending on how much you're buying. So I think there's an argument to be made that modified texture food consumers, especially pureed consumers, which can be harder to make in a way and make it acceptable, that there should be more money for food when it requires a texture. So if that can be estimated for the home and provided on a yearly basis, I think that's an appropriate advocacy that we should be doing. It does take more time for sure, and quality skill to make a nice pureed product, right? And to offer it consistently.
Yeah. Perfect. And there was a question about your 3D printing food. Can you elaborate on what 3D printing food is?
Yeah, and so it's a novel technology. So 3D printing has been around for soft products for a while, and you can see sometimes they make it with fancy chocolate, and it can be done to make a fancy mold or something like that. It takes a very long time, first off, to make. We made actually carrot medallions in a colleague's lab using 3D printer. It took about 15 minutes to make 6 medallions. We cooked our product beforehand and pureed it beforehand and put it through the syringe to be then molded into coins or medallions, if you will. Some 3D printers will actually cook the food as well, but then that becomes an issue of food safety, right? And when it takes so long to print, and then the cleaning of the machine, all that sort of thing. So it's not at a place right now because of those technological limits. But in the future, maybe it will be, and maybe it will be printed so that it is easy to freeze and take out and use again. I know there's, of course, issues with enough freezer space in homes, individual people's homes, as well as long-term care homes for that product. But that's where it is right now. It's not ready for demo use.
Yeah. Oh, it's interesting. So there was a question about, are you aware if there are any food molds available for people living in the community where they could purchase or use them? Yeah.
I don't have right off the top of my head, and maybe someone else does that can answer that in, but I do know I was actually talking to someone from a long-term care home in the GTA, Greater Toronto area, and they actually had a training program for family living with persons with dysphagia, and they showed them how to make molded food. So it must be available to people in the community.
Yeah. Okay. And any tips to support families with elderly relatives living with a disorder such as Parkinson's diseases, experiencing swallowing issues?
Right. And so I think the key is getting them assessed to determine, first off, do they need a modified texture or not, and if they're malnourished or not. People with ALS or Parkinson's will often lose significant amounts of weight, and it can affect the progression of their condition as well. So it's important to determine that and get the support they need. When it comes to if the person's malnourished, we had some ideas there already about using enhanced food products by adding energy and protein to foods and making sure that they're at the texture that the person needs. I think the training people living in the community around what is a good pureed texture, not a too thin texture, is important. They might go to a little bit too thin for folks as well. Some of the foods they might think, like, for example, their quiche, they think might be just fine, but needs to be mashed up a bit more to make it appropriate for a pureed texture. Might be a little bit too dry, for example. So you're looking at the IDSI criteria. They were created, of course, for anyone to be using. So training, I think, family members on how to use the IDSI criteria with the fork, the spoon, and the syringe, if possible, is key as well.
Okay, perfect. And we have one last question. Any suggestions on how to advocate for malnutrition screening?
Where, I guess.
Yeah, I was going to say location. I was going to say community.
Community,
In the
yeah.
community,
The hospital, I think we're making good strides with
yeah.
hospital. Over the last decade, Canadian Malnutrition Task Force has been really working hard on the hospital sector, and we're starting to move into the community sector, but that's the harder one, right? And so certainly going to CMTF, you'll see Canadian Malnutrition Task Force, there's a variety of resources available there for people to use to make the argument with their decision makers in primary care around screening. And there's tools available, different tools available for the community setting for older adults specifically. In the long-term care sector, I'm a bit of ambivalent about should we be screening, because my view is I think dietitians should be having everybody on their roster that's in the home. It's whether or not they see them continually, right? And I think, quite frankly, monitoring their weight and food intake is a better indicator than any screening tool about where they're at. And so being on that on a monthly basis, seeing how they're doing okay and stable, I think that's better than any screening tool, quite frankly, for long-term care.
Okay, perfect. Thank you so much. I'd like to thank everybody for their questions and comments today and for participating in the webinar today. We'd appreciate your feedback on the webinar, and if you could take a few minutes to answer a survey. To the left of your screen, there is a forms option, and if you click on the forms option, a survey will pop up for you to complete. And also, just to let everybody know too, within 2 weeks, the recording will be available, and also the slides will be emailed out to everyone who participated in the webinar. And I'd like to thank Professor Heather Keller for sharing with us this insightful information today. And this will be the end of our webinar, and I hope everyone enjoys the rest of their day. Thank you so much for attending.